Thanks, Kathy. Welcome, everybody. It's great to always talk at this type of audience because you guys are really the workhorses and the front lines for these patients. So it's always nice to be talking to this group. So I changed the title of the talk a little bit to Lymphatic Medicine Assessment of Lymphedema. Betsy and I say, along with others in the center, patients don't walk in the door with lymphedema. They may walk out with it, but we really try to keep an open mind of why they have limb swelling, so we're not missing something else or there's not a secondary contribution, because a large majority of patients have multifactorial edema. So vascular anatomy, I know Drew has talked a little bit about it and will more, and you've heard from Kevin about the imaging, but from a cardiologist perspective, we rarely learn about the lymphatics. We learn a lot about the arteries and the veins. Obviously, the arteries are carrying oxygen, nutrients throughout the body. The veins are the main highway carrying the fluid back. It does about 95% of the work to get that fluid back. But the lymphatics, which I can't remember learning about in medical school, to be honest, through cardiology, we never talked about it. In vascular medicine training, I barely talked about it. And it was only when I came here and really learned from Drew and self-taught about the lymphatic system and how important it is. So different than the arteries and veins. The artery and veins is a closed loop circuit. So the heart pumps blood, and that's the pressure that's going to circulate the blood throughout the cycle. There's no pumps or any extra force from the like the lymphatics. The lymphatics are a one-way road. They suck up the fluid from what we call the interstitial space. It's like the soft tissue where the fluid is lingering. That extra 5% of fluid that's not coming back through the veins is sitting and nourishing our tissues. That comes back through the lymphatics. That comes back slowly through the web-like network of lymphatics that you've seen beautifully through some of the pictures Kevin has shown. But it has its own pumps and valves. It is not dependent on the heart pressure, but if those pumps and valves aren't working well, you're going to develop a slow accumulation of fluid. So this is kind of a zoomed-in version on the right. On the left is kind of a complicated graph looking at what's called the pressure loop cycle. We think about it very frequently in the heart. So the larger the heart gets, the stronger a heartbeat will be. It's the same with lymphatics, interestingly. So they have their own muscles in there, and if they get filled extra full, they'll pump even more vigorously. And you can see the changes. You can see little peristalsis of these lymphatics. So the lymphangiome, which is imaged there on the right, is really its own little heartbeat. So it's pretty interesting. And again, not something we as physicians really focused on for a long, long time. As I noted, we really focused on the arteries pushing fluid in and the veins carrying it back. And it's all about a pressure gradient. The vessels are not overly smart. They kind of just follow where the lowest pressure is. So what we realized over time is what is going in is not fully coming out. And that's where the lymphatics are so essential, that leftover fluid that is lingering around to get it back and continue that circulation. So I say that in part because I think it's so important to understand the basics and the basics of pathophysiology to understand where we can maybe go and what we're trying to do when we're treating these patients and our future goals moving forward from a medicine standpoint. So understanding the underlying pathophysiology of lymphedema is not just a plumbing problem. So over time, you get accumulation of a significant amount of inflammation in the local tissues. This is unique to lymphedema. I see a lot of patients with heart failure, with vein disease, with low proteins from liver dysfunction or kidney dysfunction, and they don't have this level of inflammation. From there, you get thickening of the wall, the membrane wall, so that the lymphatics are not as efficient in sucking up fluid. And you get this deposition of adipose tissue. This is very, very unique to lymphedema. We don't fully understand it, but it's whatever is happening at this molecular level is causing this to occur. And over time, you get thickening of the skin. So these are potential targets, which I'll talk about at the end, for medicines. And I think ultimately, as wonderful as surgery is right now, it's going to be a combination of medicine and surgeries that, maybe it's going to take decades, but is ultimately going to be as close as we can get to a cure for these patients. I don't think it's going to be surgery alone, and I know Drew would admit that. We've talked about it a lot. And I doubt medicine alone will, but if we can target this pathway, it, I think, would make a substantial difference for patients. When we look under a microscope, you can see some of these changes. On the left is normal, on the right is someone with lymphedema, and you can see that the thickening here. I don't know if I can get a pointer here. It's working. It's not, but on the right, you can see that kind of like dark gray is the thickening of the skin and increased fat deposition. So just to step back a little bit, I think part of our goal, myself and Betsy, who you'll hear about later during our mock conference, is, again, diagnosis for a patient, just to confirm they have what they have. And a lot of it is, what is the risk factor? So identifying what is the underlying driver for their edema and why could they have developed lymphedema. So primary lymphedema, as you're all well aware, is an inherent abnormality of the lymphatic system. Patients are born with an abnormality and may not come out for decades. So there is the kind of more classic description of bucketing patients by age. If they're born with it or within the first year of life, it's considered congenital. If it's before age 35, it's lymphedema precox, and if after, lymphedema tardive. We don't really use that in our center. It's not very helpful. Whether you were 34 or 36 when you started, it doesn't really matter. You have it, and it doesn't help guide management. It doesn't help us understand why it happened either. So we don't really use those terms too much, but it's something that is frequently used in the literature. 1% of all cases, so it's a real minority, though in our center we see a biased population, so we see much more frequently. But in the general population, it's estimated about 1% of all patients with lymphedema is due to a primary dysfunction. It's rarely the upper extremity, but we do have a handful of patients with upper extremity primary lymphedema where we really just can't identify any other insult, so we presume it's primary and occurred early in life. We don't usually understand the actual problem. Is it that the patient was born with less lymphatics in that limb? And why would it just affect that limb and not both limbs? Are they actually born with larger ones, like big, baggy, almost like varicose veins lymphatics? Or do the pumps not work well? Or do the valves not function appropriately? And is it a distal problem, meaning is it primarily just involving the lower lymphatics, and that those patients generally do okay longer term, have less severe manifestations? Or is it more of a proximal issue up in the groin, and those patients have very progressive process and significant changes over time? So we're still really in the dark ages of understanding this with much detail, and clinically we're not using it at this point because we can't understand it to drive treatment. This isn't meant to be read, but this is just a nice framework of really how our colleagues at Children's will think about these patients that are coming in at very early age, and are there underlying syndromes, meaning they have abnormalities beyond just the lymphatics that are associated with their lymphedema. So probably the most common thing we see in adulthood is lymphedema distichiasis syndrome. So a patient will say they've been plucking out their extra row of eyelashes for decades. And that's something unique to what's called a FOXC2 mutation. So what's great about our team at Children's and other places around the world is looking at these abnormalities, and can we extrapolate this to older patients, and can we identify targets of what is genetically abnormal, and learning more about the disease process from these early basic science investigations. So secondary lymphedema, the overwhelming majority of patients that we see, again, some secondary insult to the lymphatic system, accounts for 99% of cases. It's relatively common, and it's probably very much underestimated if you start including other common causes like phlebolymphodema. The most common cause in the world is still thought to be filariasis, though this is significantly decreased with prophylactic medications in endemic areas. But we will ask, and we'll test for it occasionally if patients are from or have spent a significant amount of time Africa, Asia, parts of South America. So we have a great colleague that we work with at infectious disease that will kind of hone down on like what county they grew up or what town they grew up in that country and what year and what exposure rates were, and do they have other like friends at school that had large edema. So it is something we keep in mind. And it's due to a parasite. You probably need to be infected multiple times. We'll see patients say, oh, I went on a safari once, and that's not going to cause lymphedema. But if you get infected over time, multiple exposures, it causes fibrosis of the lymph node and the lymphatics. Most commonly, obviously, in developed countries is cancer-related treatment. So what is it about cancer that causes lymphedema? So it's almost never, though, is occasionally due to the cancer itself. You get direct trauma from the lymphatics from lymphadenectomy, radiation injury. There may be some chemotherapies, and chemotherapy, we always talk in conference, we have trouble keeping up with all the new chemotherapy regimens that patients are on, which is great for cancer patients, but makes it difficult for us to understand what the mechanism is and could it be contributing to their edema. But there are some that may exacerbate edema, if not being the primary cause. Lymphatic compression or lymphatic infiltration, again, if it's the cancer itself, is mucking up those lymph nodes and not allowing flow out. So breast cancer, because it's so common, is the most common cause of secondary lymphedema, but there are other cancers that are frequently seen. So you can see with sarcoma, often these are big surgeries where they're taking out big chunks of tissue and associated lymphatics. GU cancers, so cervical, uterine, and melanoma. So any cancer can do it if it's a large enough insult. So with breast cancer-related lymphedema, it's estimated between anywhere to 20 to 30%. It occurs most frequently within 3 years. About 3/4 of patients that are going to develop it will do so in 3 years, but that risk is long-term. We don't fully understand it, and Drew has spoken a little bit about some of the anatomic differences. There may be some genetic factors that differ between why one woman would get it and another woman wouldn't, despite a very similar insult to the lymphatic system. But it's clear that increased lymph nodes removed, a concomitant radiation therapy, a mastectomy rather than just like a lumpectomy, increased risk. If there's postoperative infections or seromas, those patients are at higher risk for developing breast cancer associated lymphedema. You can see here, again, those that had highest rates, where we're getting up to that 20, maybe up to 30%, are those with both of axillary lymph node dissection plus radiation. So how about the timing of secondary lymphedema? We've seen patients going out now decades from their initial insult. They had breast cancer in the 70s and didn't develop swelling until they had an IV that went bad in the hospital, 30, 40 years later. Most patients tend to present, like I said, within 3 years. This is just a nice study showing you had a significant increase over those first few years, but upwards of 5 years, that slope continues to increase. So when we see patients in clinic, we're really holding down what insult, and I'll ask patients, did you break your ankle when you were like 7? Was there anything in that leg? Did something else trigger it that could have led to a little bit of a dysfunction and then was brought out at a later age? Any type of trauma, like I said, bone fractures, blunt injury. We see a fair amount of patients that have a total hip or total knee replacement. They have a little bit of swelling postoperatively, and then it just never goes away. And obviously, it's a minority of all the patients that are getting total hip and total knee replacements, but it's not uncommon that that's a secondary hit. And there's probably something called constitutional lymphedema, which we'll talk about. I mentioned infection, filariasis in endemic places, but recurrent cellulitis can also do it. And that's obviously a bad cycle to get into. So patients will get an infection, maybe a couple. We've discussed in our conferences that maybe those patients don't have normal lymphatics, and that's why they're getting the cellulitis recurrently, though they may not clinically otherwise have evidence of lymphedema. They start to swell, it doesn't go away. They're at high risk for cellulitis. They get worsening lymphatic function, and there's this cycle that they unfortunately get into. So there's a concept primarily from Peter Mortimer in England about this idea of constitutional lymphatic dysfunction, and it's probably this overlap of primary and secondary. So we'll commonly see patients that will have, an ankle sprain or a mild injury that, a mole removed or just a bug bite without a big infection, and then they get swelling and it never goes away. And they're focused on that event and say, well, if I had never traveled or if I didn't step wrong off that step, I would have never developed lymphedema. And maybe they wouldn't have in that moment, but it's probably those patients were born with suboptimal lymphatics, and they were functioning their entire life at 80, 90%, which was just fine day to day, and then they get this second hit and they just can't compensate for it. So maybe it's not primary how we think of it, like a congenital primary abnormality, and not clearly a hard secondary where there's a direct lymphatic insult, but kind of like an overlap. So again, the term that is increasingly being used is constitutional lymphatic dysfunction. And I think it fits for a lot of our patients. So when we think of edema, again, we try not to say you come in with lymphedema, you have edema, okay, then let's assess why it's there. So it's actually a simple framework to think about. Is the limb getting too much interstitial fluid? Is there being too much produced? And we'll walk through what some of the things we think about. Or is it not being removed appropriately? And that's lymphedema. If you're not removing that interstitial fluid to an appropriate degree, that's lymphedema. But the overproduction in your lymphatics just can't keep up. That's not necessarily lymphatic dysfunction. That's just lymph system can only do so much. Often we see a combination of both. So what is for Betsy and I and others, when we see a patient, what are we thinking? So obviously we break down if it's a different differential if patient has one arm or leg swollen versus bilateral. Bilateral upper extremity is rare, but we do see it. So if it's unilateral, we're usually thinking, is there some anatomic problem? Meaning, is it a vein problem? Is it a lymphatic problem? Could there be some neuropathy or some other odd vasospastic process, which is rare? Was there a trauma, or is there an active inflammatory process? For bilateral, we have to go kind of back to our general medicine knowledge and say, okay, is there something more systemic going on? So bilateral lower extremity primarily. Could they have heart failure? Do they have cirrhosis? Do they have kidney disease? Do they have myeloma? Do they have low thyroid? Is there some medication they're on that is driving this? What is their weight? Could it not be lymphedema? It's actually lipedema. I've diagnosed, unfortunately, a lot of things that have just been missed. So we set off a lot of blood work just to check the box. We say, well, if we're going to treat you for lymphedema, let's make sure we're not missing something called nephrotic syndrome, where you're actually urinating a lot of protein. So let's make sure your albumin is normal. So again, it's rare, but we do occasionally pick things up, and we dramatically change the course of their management. For the arms, the differential is smaller. Almost all patients are coming with a clear insult to their upper extremity. So breast cancer related, clearly had axillary lymph node dissection. But occasionally we're seeing patients, they have a pacemaker or they had a port previously, and it's actually, they had breast cancer on the right, they had a port on the left, and it's actually their left arm that's swollen. And looking into the veins, and could there be some venous anatomic issue? There's an entity called Paget-Schroeder or venous thoracic outlet syndrome, where you have a narrowing of the thoracic outlet, which is where the veins, arteries, and nerves from the arms come into the chest. It's underneath the clavicle, which can be narrowed, particularly in patients that are very active. They do a lot of exercise, like painters, electricians, people are doing a lot of overhead movements, can have narrowing in the vein, and that can be a cause of swelling in the limb. So if a patient doesn't have an obvious insult from a lymphatic standpoint, we have to say what else could be going on. Or even if they do and it's a dramatic presentation, we want to make sure we're not missing something else. Bilateral upper extremity edema is very rare. For the rare patient that we do see, it's usually related to some venous process like a mass or something like that. Usually those patients are getting seen in the emergency room because it's a pretty profound presentation. So when we, again, see patients bilateral lower extremity, we say, what else could we be missing? We do a fair amount of blood work for most of our patients with bilateral lower extremity. What are their risk factors? Just take a good history. Have they ever had a blood clot before? What has been their infection history? Have they had any other trauma, cancer exposure, travel, et cetera? Any family history of limb swelling? We do a thorough exam, and I'll show you some photos, which are all very good at yourselves. And then we do a lot of imaging, and I won't go through it like Kevin did, but I'll kind of, like the question that was from the audience, kind of how we think about it and why we're selecting certain imaging versus another. For upper extremity, again, same type of thing. The differential is much smaller, but we think about it the same way, taking a thorough history and exam. Just a brief list of medications. This is a much, much longer list, but kind of like the most common insulting medications that can cause edema. When I first started with Druve, I treat a lot of high blood pressure too, and I have a lot of patients on amlodipine. And a patient with breast cancer would come in being on amlodipine. It's like, why is she on amlodipine? I was like, because she has high blood pressure. But why are you keeping her on amlodipine? Because she has high blood pressure. I said, but if it's not, I said, it's not causing bilateral lower extremity edema, so it can't be the cause. He's like, well, it's not helping, so if she doesn't need it, get her off of it. I said, okay. So that's what we do now. So almost all of our patients, we try to get them off a medication that could exacerbate edema. Because like I said before, if we think of the pathophysiology, if you're making the lymphatics work harder by exposing them to something that may produce more fluid, let's see if we can take that away. It's not going to make the lymphatic process necessarily better in terms of the lymphatic function, but it may improve their symptoms of touch and take the edge off a little bit. So we always go through patients' medicines, make sure there's nothing that we can tweak. And occasionally we'll see patients, and this is the primary problem of their swelling. This is usually bilateral lower extremity edema, because it would be symmetric if it's primarily from the medication. Like I mentioned, venous outflow obstruction is an important thing to identify. You'll hear a case later where it was really instrumental in improving a patient's edema. I think it's important from a therapy standpoint that if you have a patient that you think is being adherent, they're coming in, they're getting wrapped, you're doing complete decongestive therapy, and they're just not responding, and you're just like kicking yourself, like, what's going on here? It's probably something else that's driving it. And it's most frequently, there's a proximal venous outflow obstruction. So whether they have a concomitant pacemaker, they had a prior blood clot, they have, well, unfortunately in our patient population, they have a mass or a representation of their cancer, and there's a mass pushing on the vein. And you can try as much as you want to push that fluid out, but a lot of the way that the lymphatic therapy and compression works is moving the fluid into the veins, not necessarily getting them out of the lymphatics. But if the veins are also blocked, there's no way out. So these patients tend to be very difficult to manage. So if you know, you're like, I'm just struggling here, what's going on? Consider having them be seen for some venous imaging. So here's just a look at a patient. It's kind of a zoomed in version of a patient. That's their chest wall. And you can see kind of a prominent vein going across the chest wall. We usually don't see any varicose-like veins on the chest wall. So if you do, it's probably something abnormal with the venous outflow. So worth a look. There's an entity called May-Thurner syndrome, which is a compression of almost always the left iliac vein. So in a patient that has unilateral left leg swelling, and again, if you're just not getting the response you think you should, or their exam doesn't look classic for lymphedema, particularly if it's a younger patient, they don't have a classic insult, or they have a lot of varicose veins, this is something to consider. There is also a clear overlap between venous disease and lymphatic dysfunction. So this is a nice study. It's really old. I think it's from like the 90s. But I think it's a nice study because it illustrates nicely how there's an a clear association between worsened venous disease and associated lymphatic dysfunction. So over time, as these patients have high pressures in their veins, they overload the lymphatics, and the lymphatics just can't take it, and over time they start to get tired. And so this is a lymphoscintigraphy study. So on the y-axis is just kind of the rate of uptake of how much of the dye that Kevin was talking about is lighting up in their groin. You can see as the patient's on the x-axis, so normal, varicose vein patient compared to a patient that had an ulcer, so more severe venous disease, their lymphatic function worsens. So we know there's a clear overlap, and the kind of term is phlebolymphodema, and it's probably the most common cause of lymphedema in the U.S. We don't really think of it as that, but there's so much venous disease and there's so much obesity that most obese patients have chronic venous hypertension, even if they don't have large varicose veins. The pressures in their veins are chronically elevated, and that's going to drive excess interstitial fluid, make the lymphatics work harder, and that's going to lead to some can lead to some lymphatic dysfunction over time. This is also a really nice study from Dr. Green, our partners at Children's. So though he sees a lot of children, he also sees adults, and he had a specific interest in evaluating patients with morbid obesity and swelling. So he was really the first to describe, though now we kind of take it for granted, it seems obvious, that there is a clear lymphatic dysfunction associated with elevated BMI. So these bars are different levels of BMI. You can see on the bottom going from kind of borderline overweight to more clearly obese to kind of morbid obesity on the right with BMIs in 60s, 70s, 80s, 90s. Unfortunately, this is not that rare. And you can see the more black in that bar, the more percent of patients that had an abnormal lymphoscintigram based on their weight. So when you start to get it to a BMI of about 50 or more, you have a greater than 50% chance of having lymphatic dysfunction. So it's not uncommon that patients come in, they're like, why am I swollen? It's like, it's your weight. It's a very difficult problem to solve, but it's actually a very simple diagnosis for us to make. We still keep in the back of our eye and make sure they're not having something else. And unfortunately, there's a lot of heart failure associated with obesity too. So for many of these patients, we're sending them for a heart evaluation too. So just some pictures. Again, your group is so good at seeing these patients and understanding the exam, but just how we think about it a little bit. So pitting is essential for understanding how patients are being controlled and what type of surgery they may be a candidate for, or do they need to be optimized before surgery. So obviously you see a very large right leg here for this patient, still a fair amount of pitting, has kind of a classic, we talk a lot on conference, like that's a visual stemmers. Obviously we can't pinch it, but you could tell if you try to pinch it, you wouldn't be able to tent the base of the second toe. Get a lot of questions of, do I have cellulitis, or I've been treated and it's not getting better, I'm on like my third course of antibiotics, and there is a high rate of just dermatitis and inflammation in the leg. So this doesn't necessarily need to be treated. Certainly if a patient is having rapidly progressive symptoms, they're systemically feel unwell, they fevers, et cetera, and we tell patients it can be difficult, and sometimes we just have to treat you because we're not sure, because you're at such high risk for getting sick if we don't. But if it's not getting better and it's kind of, and they're otherwise feeling well, it may just be dermatitis. This is a nice image of a patient with primarily venous disease. So the classic description is an upside down champagne bottle. Rather than lymphedema, you get more of that tree trunk appearance. With primary venous disease, you get more of this contraction down in what's called the gator region, between like the ankle and the lower part of the calf. And you get that skin thickening, that hemosiderin deposition, that iron brawny appearance. And the skin tends to be very, very firm. And then, as I mentioned, you can get phlebolymphodema as well. So this is a patient that has bilateral kind of swelling, but on the right looks more primarily like venous disease, where on the left more like phlebolymphodema with a little bit larger girth lower down in the leg, more edema into the foot. And this is his left foot. You kind of zoom in, and again, there's that visual stemmer sign. So it has that overlap of lymphatic and venous disease. This is a patient with primarily lipedema. Not a focus of this talk, in something that is can be a real challenge to diagnose. And there may be some overlap with lymphedema. Though our center tends to feel that there's lipedema is one thing, lymphedema is another, and they're kind of two separate disease processes for the overwhelming majority of patients. Certainly, a patient can have as many diagnoses as their body ends up having, but for most patients, it's kind of a separate disease process. But it can be very illuminating for these patients to say, actually, you don't have lymphedema. They have unnecessarily similar names. You have lipedema, but they're treated very differently. Patient with primary lymphedema with severe manifestations of the toe, Again, a patient with a little bit of venous disease. You could see that hemocentrin deposition, that brawniness, that kind of little bit of contracture down in that gator region compared to the true tree trunk, but also has some lymphatic dysfunction. Again, here, similar, an overlap. Patient with obesity. This is kind of like the classic combination. Betsy and I feel like we see this the most, is patient with a little bit of heart failure, they're overweight, they have a little bit of venous disease, and have some lymphatic dysfunction. And just a kind of classic breast cancer related, can be very, very subtle. I always look at the patient's hand. If it's not obvious, just looking at their arm, you look at their hand, and you can see, this is a nice example of like losing the tendons in the hands and the veins. It can be very subtle otherwise in terms of the exam changes. And then just another patient here. And then again, a patient with long-standing primary lymphedema with those really dramatic changes in the toes. Patient with papillomatosis from, again, primary lymphedema with changes in the toes. A patient morbidly obese, a disease exclusively seen in obese patients, massive localized lymphedema. It tends to involve most commonly kind of the medial portion of the thigh, and it will overhang lower down, but we've seen it in the scrotum, lower down in the leg. These patients just need, not just need, but they need to lose a dramatic amount of weight, and having that reality check with them. And Drew will happily operate on them when it's safe to do so, and that requires their weight to get down and really decongest this. And it won't necessarily completely resolve with weight loss, but you're left over with the residual soft tissue, and that's much easier to manage either medically or surgically. And just a variety of different skin changes, the cobblestoning, the lymph cysts, so things that are pretty unique to lymphedema. All right, so how do we use imaging? So we evaluate both the venous and the lymphatic system with ultrasound, which you heard from Drew with high-frequency ultrasound. From our purposes, almost all patients have already gotten a venous reflux study to see if they have varicose veins that we can visually identify. It's very, very common. So even if we see someone with a positive or an abnormal reflux study, we still evaluate them for considering lymphedema. Like I said, there could be overlap, or a patient may just have varicosities and lymphedema. We use a lot of nuclear lymphoscintigraphy, not so much for diagnoses. I think if it's a slam dunk based on exam, we're not going to get it. Like we heard, it's a little painful, has a little radiation. It's not going to add much. If a patient's not interested in surgery, they had clear breast cancer insult, there's no other concerns clinically for something else going on, then we don't do it. We get it for all our pre-op patients, and it's also very helpful for patients with primary lymphedema, and they're like, is this lymphedema? I've been walking around for 10 years, no one can make the diagnosis, and I tell them I think it's lymphedema, but they want a study to confirm it. This gives us great objective data, and overall it is safe and very, very accurate. We'll also get it in patients we see, we're like, I'm just not sure what's going on, so let's get something, let's check the box and make sure it's not lymphedema because I'm otherwise not sure. And then that's an upper extremity. And you guys heard a little bit of ICG. We'll use this occasionally for diagnoses if we're having patients, particularly with primarily distal findings, so just swelling in their feet, but the rest of their leg looks good. We may do a lymphoscintigram and they have good uptake, but we do an ICG and they just have very subtle abnormalities in the foot. So we get a little bit more detail there. And then something Kevin didn't talk too much about, but invasive lymphangiography we'll do with our colleagues, Jeff Weinstein, primarily of interventional radiology, where he'll inject a contrast agent called Lopidol directly into the lymph nodes in the groin and watch how it travels up. We're primarily using this for not so much diagnosis, but understanding of a patient's particular anatomy. So for our primary patients, we're not exactly sure what's going on. We're not actively changing management generally with this, but it's for patients that are interested, and we're interested in learning more. We're also doing it more and more for central lymphatic obstruction. So for patients that have either fluid accumulation, something called the chylothorax, lymph fluid in the lungs or in the belly, and trying to better understand the interaction, which is kind of a whole different talk in itself, of the circulation, the central lymphatics, and heart failure, and ascites and pleural effusions. More to learn. And then I really love MRI for identifying patients that are pretty confident that they have edema on exam. I'm sure you've all had these patients that come to you, they say I have lymphedema, and you kind of look at them, you're like, I don't really see anything, but they feel better with therapy, so they've been seeing you for months, and they're getting MLD, and they feel much better. Then we see them, we're like, I just don't see any edema. They get an LDEX maybe, which is normal, and we just need to get an MRI to say, like, I don't think you have anything, the LDEX is normal, and we get an MRI and they have no edema. And that can help move them on to a different diagnosis that's non-lymphatic. So in terms of our treatment, unfortunately, this is kind of the shortest part of our talk and our role at this point. Hopefully in 20 years, this is a much more complicated talk. We really try to to put the patient at the center of it. Betsy and I are usually seeing the patients first, as Kathy mentioned. Often we're seeing them in tandem with our physical therapy team or an occupational therapy team. If the patient has a local therapist, we see them, we get measurements, we just have all our baseline information, and our goal is to send them back to their local therapist, because that's where they get their best care, where they can be seen regularly. Only if the patient is local to us are we saying, come here for regular therapy. Otherwise, we're really trying to connect them with their local therapist. And we may get baseline measurements with the tools we have available at our center. So medications to target, like I mentioned, this is not just a plumbing problem. So Dhruv is doing his best to help the plumbing, but there's some other processes that we have to get better, which we can do, I think, over time from a medication standpoint. We have to target that inflammatory response, that fibrotic response, why that fat is depositing, we don't understand. But if we can identify the molecule and the mechanism, just like we can do for patients that develop atherosclerotic plaque in their coronary arteries, we give them cholesterol-lowering medicine. There may be some equivalent in time for lymphatics and decreasing that process from occurring. So then maybe it is primarily just a plumbing problem. Now Dhruv's surgeries are that much more effective because we've taken away all that extra stuff that's accumulating, and now we just have to remove the fluid, which would be relatively easy. Are there ways to increase or regenerate lymphatic vessels with gene therapy or giving growth factors or putting in scaffolding for when a lymph node transplant is done, that it takes better and it grows more efficiently? So this is just a nice schema of looking at all the different mechanisms of why a lymphatic vessel may not work appropriately in potential targets. There was one promising target a few years ago called leukotriene beta 4, and it was targeting that inflammatory process. It was identified, the mechanism was identified by Dr. Stanley Roxon at Stanford, and unfortunately on studies, when they looked at it, it just didn't help. It worked really well for mice tails, but unfortunately not for humans. So we haven't seen the final publication of the trial, but based on preliminary results, it was not effective. There is hope for another anti-inflammatory called ketoprofen. It's an NSAID like ibuprofen, but has a little bit more focused mechanism. It was given 3 times a day for 4 months, and they saw decreased skin thickness, but not much in change of actual volume accumulation or limb volume, and it has a black box warning because it can cause a lot of GI effects and for older patients, cardiovascular effects. So it's not something, I think I prescribed it once for a patient that had a lot of dermatitis, just to see if it would be helpful, and it wasn't. But so not something that is regularly being described. Again, not meant to be viewed, but this was from a review that came out earlier this year that looked at all the attempted targets. So they're there, we just have to identify them better and find better mechanisms to downregulate them. So to the point that was brought up earlier, just a review that this was presented by Betsy at the International Society of Lymphology Conference in Italy a couple months ago. We looked back for about 1,800 of our patients that Betsy and I have seen, and what kind of imaging are we doing? How frequently are we doing imaging? So about 20% are getting nuclear lymphoscintigraphy. This is either for diagnosis or preoperatively. 10% are getting MRI. Again, not always preoperatively, but occasionally. And invasive lymphangiography is just a small handful of patients with primary lymphedema or edema that we can't figure out, or again, have fluid accumulation in atypical areas. In terms of the surgical volume, you can see less than 10% of the patients are getting surgery. So the overwhelming majority of patients are just seeing us. That's either because they don't have lymphedema, or they have a BMI that's too high, the threshold 35, or they're not otherwise optimized, or they just aren't interested, which is certainly fine. We tell patients our goal is not to get you to lymphatic surgery. Our goal is to make your quality of life better with whatever way we can do that. So what is our role when they come to lymphatic medicine? They're often very confused of why they're seeing a cardiologist or a cardiology NP, but we tell them that we are blood vessel specialists, and lymphatics are a very, very important blood vessel that no one's been thinking about for too long. So our goal is to assist in diagnosis. A lot of patients want to know, am I going to get worse? What is my prognosis, especially with primary lymphedema? Optimize their conservative therapy, working with their therapist or our therapy team, making some tweaks to their compression, or sometimes just telling them, I know you haven't seen a therapist in 5 years, but it's time that you see one, and because they felt they were frustrated with their last one or it just hasn't been helpful, and trying to just give them a little more reinforcement that it can get better. It just takes time. It's unfortunately a disease that takes so much patient effort. Compared to treating high blood pressure, that's easy. We give them pills. As long as they take their pills, we can get it down. But this is like hours a day that they have to devote. So it's very, very difficult, and we try to just reinforce that they have to do it, and we understand it's difficult, but that's really the only option for most patients at this point. We review if they're appropriate for surgery, if that's what they're interested in, go through some of the basics of the surgery. We talk about their genetic risk. We have some young females that maybe of childbearing age, and if we can identify the actual gene, there's something called selective fertilization, where you could select the embryo that doesn't have that defect. So there are some options for our younger female patients, and we send them next door to Dr. Green for genetic testing and then take it from there. We obviously try to manage alternative causes, so if they have heart failure, if they have venous disease, we try to take care of that, or if we don't, identify colleagues within our institution that do. A lot of reassurance and support, try to tell them that you're not alone. We had a lady that came from Minnesota last week that I said, you know, you're doing a really great job. She didn't have much pitting. She's like, I never been told that before. And I like kind of just said it because you're doing great. This looks great. You have such little pitting. And she like started to cry. She's like, I've never been told that before. So just a lot of reassurance and comfort. And this is, again, you guys are on the front lines. You understand how important your role is. We try to just add to that. We try to connect patients with therapists that can't identify one locally, facilitate compression if they're having difficulty finding it or affording it. And then we use a handful of pneumatic pumps, which I won't get into too much. So I'll stop there. I appreciate your time. Thanks for being here, and take any questions.
Thank you. I'm just wondering where the research is on adipose-derived regenerative cells, and if you guys know anything about that, or if that's being done here at all.
Say that one more time, I'm sorry.
Adipose-derived regenerative cells?
I don't know, Drew, do you know anything about it?
Can you say more about that?
It looks like it's pretty early in the research, but it's about stem cells generally derived from the adipose tissue injected into the axilla of patients. I think they're doing it in Denmark.
Don't know about that. So the interplay between lymphatics and fat is very interesting. In the operating room, when we operate on lymphatics, fat is basically glued on lymphatics more so than any other vessel. We are interested, and maybe this is somehow related to a similar topic, is we are interested. We know 80% of our patients, whether they're primary or secondary lymphedema, show up with fat hypertrophy. So they have fat hypertrophy in the limb, and we do not understand why that's the case. So we're working with Greg Westcott, Evan Rosen, who are NIH-funded endocrinologists at BI, and we're taking fat samples in patients who have fat hypertrophy in one extremity, the lymphedematous extremity, and comparing that to fat samples in the normal extremity. And we're looking at what signals, and this does come down to precursor fat cells and what's going on in those cells, and we are starting to see different signals in those cells. And so that is an ongoing research study that we have, but we have not been injecting fat into the axilla or anything like that to treat lymphedema. I think we just have to be a little careful with that, because in breast reconstruction, for example, which I still do a bit of, is when somebody has a tumor bed where even the tumor's been excised, we are hesitant to go inject fat back into that tumor bed or that prior tumor bed. For example, if somebody has a divot on their breast, we do not like to lipo another part of their body and inject fat, because there's some data, albeit soft, that can cause angiogenesis and potentially potentiate tumors. So I'm not familiar with that, but on first glance, I need to read a lot more before I'd ever advocate something like that for a patient.
Yeah, this question is for anybody on the faculty. Brett, you mentioned central lymphatics. So we're seeing a notable number of patients with either proven or suspected central lymphatic dysfunction. I know Dr. Icken at UPenn is doing his work, but I was wondering, is there a drive to image, to operate on, to do more work with central lymphatics? I ask that both with academic curiosity, but also, where can we best refer these patients?
Yeah, it's a good question. Drew works closely with Dr. Icken for some of his studies, and we've talked about patients, we've shared patients, and Dr. Weinstein, our interventional radiologist, has gone down to learn from Dr. Icken. So we can do, we're certainly not as experienced as Dr. Icken, but we can do I think all the imaging they can do. Can we intervene like they do and interpret it? Probably not yet, just because we don't have the experience. We're happy to see those patients. I think we, as a medical community, are still understanding what that means. What is central lymphatic dysfunction, and what is clinically coming of that? I'm hesitant at this point to say a patient that has anatomic narrowing, meaning like they have a lymphangiogram and their thoracic duct looks narrowed, but doesn't have edema anywhere, to say they have central lymphatic dysfunction that's leading to any clinical sequelae. I may be wrong, and we're going to have to learn more, but certainly for patients that have, like I mentioned, chylothorax, so they have accumulation of lymph in their lungs, in their belly, have refractory heart failure, that maybe there's a role there to look at the central lymphatics, the connection between the, just so everyone knows what we're talking about, the connection between the thoracic duct and the vein. There's a little valve there, and it can be stenosed or narrowed over time. And down in UPenn, they're doing a fair amount of either rerouting or stenting to try to improve the flow. I don't think for most peripheral lymphedema that's going to be helpful, just because the issue is more distal. But for patients, if there is a patient that has swelling all over, maybe, I'm still not, I'm hesitant or guarded in terms of what we do for those patients at this point. In terms of intervention, I think we just need a little more experience. But I know Drew has a lot of interest, and we as a group have a lot of interest about learning more. Certainly if you have those patients, we're happy to see them. But we try to be guarded with them that, like, we don't know what we're doing. As in, we don't, Dr. Icken doesn't, no one really does in the medical community. So, there's no real like, oh, I have, patients come in and say, I have central lymphatic obstruction. How do you know that? I know. Okay. Well, we need to work through this a little bit before we can act on it from a medical standpoint. But I think it's super interesting, and I think we're going to learn over time. It probably plays a much larger role than we've understood in the past.
I'm just going to jump off that. I think this is why Brett is such a great partner in all of this, is he's very objective as well. Like, we got to see it. If we see a target and there are symptoms associated with it, we will go after that patient in a central way, just as we do peripherally. I'll tell you, about a year ago, and Brett mentioned Jeff Weinstein. Jeff Weinstein runs the interventional side of our center. We went down to visit Max, and Steve Kovacs, my contemporary, or my plastic surgeon over at Penn, and we watched them do a central case where, they were able to image the lymphatic system, and they found the thoracic duct was about 8 millimeters, and the patient had GI symptoms, protein-losing enteropathies, and Steve went in, opened up the neck, disconnected the thoracic duct, and inserted it into the EJ, to basically bypass the entire lymphatic system to the venous system. Could we do that? 100%. But we have not found the right patient. We haven't seen the right images to do that. But in frankness, we are screening our patients more, making sure they don't have GI symptoms or other things that we could be missing on a central side. So we are aware, we're capable, we're just not seeing the right patient yet. And Jeff's telling me the same thing, but we're happy to see these patients and work them up.
I wonder sometimes what's the chicken and what's the egg with venous disease. Is it the lymphatics that's not working? And so now we don't have healthy tissue in our venous system, or is it the venous system that's starting to fail and there's too much garbage out there and the lymphatics can't keep up? There's not enough garbage trucks.
No, it's a good question.
What's the chicken and what's the egg? And that might be the same thing with the central system. Because if you think the lymphatics is really the garbage pickup of our body, right? So if we don't keep our tissue healthy and clean, eventually we're going to get some kind of, damage.
Yeah.
So where does it start?
Yeah, Max has described he gives talks, and I always try to listen because we're trying to learn more, and he says there's debris there. And we're like, well, people have asked, like, what's that debris? He's like, I don't know, it's just stuff. It's like, all right, well, so maybe that's what you're describing. There's like something there.
It's also not what the venous system doesn't return, but it's also, when we have processing happening in our body, when we're burning our proteins and stuff, we have discard. So that's garbage.
Yeah, I think
or a cancer cell, that's stuff the body starts to make that's garbage that, needs to be.
Yeah, there's a lot to learn.
I think so.
And remember, at least from the surgical standpoint, the ones that are vetted by Brett and Betsy that come to us, the overwhelming majority of those are cancer patients. So we do know the chicken and the egg. We know exactly where the insult occurred and what led to it. But your point's well taken.
Thank you, everybody. Have a good day.
Thank you. So, thank you, Brett.